Transitional pain medicine, new era, new opportunities, and new journey. I don't have any conflict of interest. In this lecture, I will go over some definitions, backgrounds, why it's important, epidemiology, some theoretical mechanism, risk factors, prediction, prevention, how to build a transitional pain service, and some future recommendations. So we'll get started here. One of the problems that we encounter in the literature until recently that there was no consensus on the definition of chronic post-surgical pain. So you will see some studies, they use the cutoff of 1 month, some 3 months, and other 6 months. Therefore, the International Association for the Study of Pain, IASP, defined the chronic post-surgical pain, or the other name, the persistent post-surgical pain, as clinical discomfort that lasts more than 3 months post-surgery without other causes of pain, such as chronic infection or pain from a chronic condition preceding the surgery, for example, cancer recurrence. Because this is important, and just to make sure we are using the same definition, the new version of the ICD, namely the 11th version, added a code for the chronic post-surgical pain and defined that as pain developing or increasing in intensity after a surgical procedure in the area of the surgery, persisting beyond the healing process, means at least 3 months, and not better explained by another cause such as infection, malignancy, and a pre-existing pain condition. Very comprehensive definition that I would use. Now, what's transitional pain? So it's the pain that pass the acute pain duration and not yet reaching the definition of chronic pain. So we all know that the literature defines chronic pain more than 3 months. And at least that's what the definition that we saw just in the previous slide. So what about these patients who are beyond acute pain, let's say 1 or 2 weeks, but they are not yet 3 months? So we have a gap here on the definition and on a service. This is why the new model now suggests to add, to cover this period, what we call the transitional pain. So it's a transitional pain because it transitions the patient from acute to chronic. Now, building on that, we came up with the new terminology, transitional pain medicine, which is a medical field that focuses on understanding the mechanisms of chronic post-surgical pain and finding out the risk factors and preventive and treatment measures. Because chronic post-surgical pain occurs from a planned incision on a planned and specific time, then you would think there is a potential to prevent this pain, or at least better control it. As with many other chronic conditions, early intervention is likely to improve outcome. So identifying patient at risk is crucial. Okay, so how common is this? Because as I mentioned, the variety in the definition in the past, we had a hard time to establish a good picture on the incidence and prevalence of chronic post-surgical pain. However, what we know now that it's far more common than most of the post-surgical complication and long-term consequences. Indeed, now if you look at many of the literature, the prevalence can be higher than 20%, especially with certain procedures, surgeries like thoracic, breast, inguinal hernia, lumbar spine, knee, hip replacement. So what we did, this is a paper that I wrote with my colleagues and still under review. So what we did some systematic review looking for published data on chronic post-surgical pain, and we have this schematic presentation. So starting from the open heart, uh, as you see, we didn't find data on 3 month or 6 month, but we found data on 12 month. So at 12 month, we have 28%. 13% were moderate pain and 4% severe. If we look at the inguinal hernia repair here, so we had some data on 3 month, 12 month, and even 2 years. So if you look at 1 year, you have about 6% and 4% at 2 years. Total knee arthroplasty, 3 month, almost half of them. 6 month, 1/3 of them. 6 month, moderates to severe, 21%. 1 year, moderate to severe, 16%. Very high incidence. If you look also at the ankle and foot surgery here, up to 12 months, you have 1/5, 21%, they have moderate to severe pain at risk, and 43% they have moderate to severe pain with walking. Looking on the other side here, if you look at the thoracic surgery, even with thoracic scope, it is lower than open thoracotomy, but you still have a very decent number. So if you look at 6 months, about 25%. Interestingly, what I have seen multiple times in my clinic, that these patients sometimes not necessarily have pain from the incision of the camera or the scope. Sometimes they came with pain from the incision of the chest tube, because most likely this is at the end of the procedure. You do it blindly, quickly, so you may injure the intercostal nerve. Again, liver surgery here, colorectal surgery here, more surgeries here, craniotomy, thyroidectomy. I will leave this image for you. You can go back to it. C-section, interestingly, up to 1 year, you can have up to 10% with chronic post-surgical pain. Hysterectomy, emergency laparotomy, mastectomy, and then here, ear surgery, shoulder replacement more than 3 months. About 16% have moderate to severe. Spine surgery, especially scoliosis, on the higher side. Laminectomy, spinal fusion, also on the higher side. Total hip replacement as well, and of course, amputation. So what can cause chronic post-surgical pain, or transitional pain, if you wish? So there are some theories which I will go over, and the honest answer that we don't know for 100%, but we think peripheral sensitization, central sensitization, conditional pain modulation, and definitely opioid play important roles. Now, the transition from acute to chronic pain is really complex. There are inflammatory and immune response to nerve and tissue damage can result in both peripheral, which is at the level of injury, which is called peripheral sensitization because at the level of peripheral nervous system, and central sensitization because at the level of the spinal cord and brain. So chronic post-surgical pain can occur secondary to perioperative nerve and muscle injury. So don't even think that this is just nerve, even muscle injury. So mechanism of injury, it's not always direct, which is straightforward. You cut the nerve with cautery or with a knife, but also indirect, like ischemic injury from prolonged retraction, use of tourniquet, tight belt, and you name it. Or entrapment, which can happen not necessarily in the first week. It will take some time because Now you develop a scar tissue, and that scar tissue can entrap nerve at the site. The mechanism and degree of injury may determine the severity and duration of pain. And after initial injury, peripheral and central sensitization may develop, which can cause chronic post-surgical pain. As such, we appreciate the importance of applying preventive analgesia to avoid such sensitization and subsequent chronic pain. So this busy table here compare in depth between peripheral sensitization and central sensitization, what trigger them, what kind of changes can occur, what chemical mediators, and what they can lead to. We'll not go in detail for the time here, but peripheral sensitization, it's around the site of injury, and it lead to primary hyperalgesia, which is an exaggerated response to pain at the site of injury. So the end result can be hyperalgesia at the site of the injury, while central sensitization can lead to allodynia and secondary hyperalgesia, which is an increased pain response evoked by stimuli outside the area of injury. Example of that will be the CRPS, the complex regional pain syndrome. Now, another important theory is the conditional pain modulation. Conditional pain modulation. So normally we live in a balanced state between pro-nociceptive and anti-nociceptive system. What happened during the surgery, that surgery activate the pro-nociceptive. So the pro-nociceptive is the green line here. So you have a surgery that activate the pro-nociceptive system, and then it took a while until our body counteract that with activating the anti-nociceptive system. So eventually you will go back to the equilibrium stage, and then the patient will recover, and everything will heal and you don't have pain. That's normal. But any imbalance between these two systems, like let's say you have a stronger pro-nociceptive, can lead to persistent post-surgical pain. And this imbalance can happen secondary to defects in the recruitment of anti-nociceptive system. For example, the pain is so severe and so prolonged that the endogenous system is exhausted. So here it tried to try to activate, but you have a really severe and prolonged pain here. So you already exhaust the anti-nociceptive system. So you end up with imbalance that will lead to prolonged recovery and chronic pain. Another potential cause here is the latent pain sensitization. So this is typically happen in patients with chronic pain and chronic use of opioid. Why? Because to start with, we have a high level imbalance between the anti-nociceptive and the pro-nociceptive. So when the surgery come and stimulate the pro-nociceptive, we already have imbalance, and we already have an exhausted anti-nociceptive system. So this is why you have a hard time to get this patient equilibrium between the two systems, and again you end up with prolonged recovery and chronic pain. So understanding this theory will help explain why preventive analgesia is a key player to prevent chronic post-surgical pain. You really want to prevent that massive stimulation of the pro-nociceptive system here, and you want to help your body with the anti-nociceptive system. You want to prevent the primary hyperalgesia. You want to prevent the secondary hyperalgesia. And how you do that? In order to provide a good preventive analgesia, and this is, by the way, in I cover that in my lectures in acute pain service. I believe that was in the first lecture. So three things need to happen. One, you have to have a deep analgesia enough to block all the nociceptive input during surgery. Two, the analgesia need to be wide enough to cover the entire surgical field. So for example, if you have a big laparotomy incision and you put the epidural not at appropriate place and you end up covering half of the incision, then this is not in covering the entire surgical field. The third thing, which is very important, and I see that every day in our practice, not necessarily at Stanford, like in general practice, the duration of analgesia must cover entire perioperative period. So example here, anesthesiologists do a very good job in managing the pain during the surgery and in PACU. But what happened after that when the patient go to the floor, day 1, day 2, day 3? So again, depth of analgesia, covering the entire surgical field, and the duration of analgesia. These are the three key factors for successful preventive analgesia. Now, what are the risk factors for developing chronic post-surgical pain? So I divided them as preoperative, like pre-existing pain, preoperative opioid exposure, and some genetic factors like polymorphism and COMT and other receptors. Psychological factor is a big thing. Presence of anxiety, depression, pain catastrophizing, lower cognitive dysfunction also may play a role. Then intra and post-operative, we have intensity of acute post-op pain, and other mean poor management of acute post-surgical pain. And this is the most important factor, and it's the most modifiable factor as well. Nerve injury due to surgery also preventable if you use a less invasive surgery, careful with the dissection, careful with the retraction. So this is also proportional relationship to the chronic post-surgical pain. Potential risk factor, immune activity like inflammatory response, and then perioperative high dose of opioid in general, but most of the studies were focusing on remifentanil because that can activate the NMDA receptor and or glial cell, resulting in a higher pain score, higher opioid consumption, and a higher postoperative acute hyperalgesia. Now, procedure related, obviously, the more extensive the procedure, the more tissue damage you have, the higher the risk. So this is why procedure like amputation, thoracic, breast, inguinal, they are well known to have a higher risk for chronic post-surgical pain. More specific for certain procedure, use of radiotherapy after surgery, and in breast surgery, and until recently, breast implant was commonly used. That also showed that it caused chronic post-surgical pain. So the new practice now to stay away from that. Now, this is again in my manuscript that's still under review. So what we did here, as in the manuscript, part of the systematic review, we did a PubMed search looking for risk factors for chronic post-surgical pain. And then we put them on an Excel sheet, and we count how many each factor was mentioned on the literature, and we order them from the most common to the least common. So the size of the books correlate with how common was mentioned. So in another word, the bigger the size is, more important and more founded risk factors. So you can think about that this is really the important risk factors. And of course, Number one was severe, poorly controlled acute post-surgical pain, preoperative and anxiety, depression, perioperative pain intensity at the site, sleep disturbance, female, younger, increased duration of surgery, postoperative radiotherapy, and you go on. So how can we predict chronic post-surgical pain? So if you use the above mentioned risk factors, and you might be able to predict. So there are multiple attempts to do that, but really recent meta-analysis showed that existing models are at high risk of bias and affects their reliability to inform precision. So recommended more research on this field. Now, can we prevent chronic post-surgical pain? There are multiple attempts, multiple studies showed multiple medication, but overall, these studies, they have a lot of shortcomings, include small sample size, lack of appropriate control, and blinding. But things that are promising in the literature, regional anesthesia and analgesia, pregabalin, and lidocaine infusion, and ketamine infusion, and behavioral therapy. Preoperative opioid use is associated with increased incidence of persistent post-surgical pain. This has been documented in multiple studies. So decreasing opioid preoperatively can improve outcome at 6 months to 12 months after surgery. Reducing perioperative use of opioid by application of multimodal and regional technique could potentially reduce the risk of chronic post-surgical pain. So keep in mind that preventive analgesia factors that I mentioned in the previous slides. So it's more about the concept of preventive analgesia and multimodal analgesia, regional analgesia, than single specific modality. Postoperative opioid is a big problem when patients complain about persistent post-surgical pain after discharging. Providers often immediately re-prescribe opioid to address this in acute postoperative setting. Represcribing opioid is usually done without a long-term plan or sometimes even appropriate risk stratification and follow-up. So one study showed that patients who received a second prescription of opioid within the first postoperative week had almost 50% decreased chance of still taking an opioid medication 1 year after surgery. So it's important when your patient second week still have pain, ask for refill. It's important to set up an in-person visit with the surgeon and even the primary care physician. And if things are out of control, it's very important to get a pain specialist involved early on in the process. Now, transitional pain service. All what I mentioned is just to come to this conclusion. So we have a handful of good, successful examples of establishing transitional pain service. This concept started actually in Toronto University. It was the oldest one by Dr. Clark. And then Duke, Salt Lake, Stanford, Vanderbilt, Johns Hopkins also have different examples. So this is a referring criteria that Toronto General Hospital used to refer the patient to the transitional pain service. I will not go over the details for the time, but basically there are some pain alerts. There are severe pain, the amount of opioid use, and some psychological factors. If you look at Vanderbilt consultation criteria for the transitional pain service, it's slightly different. It depends here on the dose of opioid, history of opioid use disorder. They use the ONIT criteria, which is the opioid naive exposed tolerant criteria. And I cover this criteria in one of my lectures in the APS lectures, lecture number 4. And then here is another hospital, the VA hospital in Salt Lake City in Utah. So here they start implementing their GPS system. So on 2017, on average, if you look about 10%, they had still using opioid 90 days after the surgery. After they started the TPS implementation in January, then they rapidly decreased that to zero. However, what's important about this is a VA system. So here we are talking about slightly different population, different health system, and whether this can be generalized or not to be determined. This is what I call the ideal model, or at least I think the ideal, or we think as a ideal model. So it really depends on multidisciplinary approach. So you have a pain psychology component, pharmacology component, and procedure. All of them work together to build this transitional pain service. So pain psychology will specifically provide support and education for patients with an anxiety, depression, catastrophizing. Pain expectation is a big thing, which the surgeon, the anesthesiologist, the team need to work on that. Then pain management will be mostly to deal with patient with uh, opioid to start with. So buprenorphine management, opioid tapering, maybe starting these patients early on in neuropathic medication like Lyrica or gabapentin, because remember this need time to work, so maybe start this patient at risk early on. Some nutritional supplement, maybe SNRI like duloxetine, again need time to work, need time to build in, need time to help the system. So for example, if you have patient with baseline anxiety going for surgery, have another risk factors to develop chronic post-surgical pain, may develop neuropathic pain. So it might be wise to start this medication few days before the surgery on SNRI. The pain procedure basically providing regional analgesia, epidurals, good placed epidural, early on radiofrequency neuromodulation, peripheral nerve stimulator, cryotherapy, and blood patches for those who develop CSF leak. Acupuncture might have a role, but the point that it's again providing some procedures with some pharmacological management, with some psychological support. All of this can be the component of transitional pain service. So to conclude, this is all sounds good, sounds great. Um, I guess all of us agree this will be helpful. However, when it comes to how to implement or how to start transitional pain service, we have some challenges. Challenges related to lack of specialized staff and resources. So it's important to incorporate such training on chronic pain fellowship, for example, psychology part, procedure part, pharmacological part. Uh, Also, you are dealing with multiple stakeholders, hospital administration, insurance maybe, surgeons, patients, and financial incentives. Who gonna pay for this procedure? Are the hospital losing money? Is this how you're gonna convince these payers that this is really eventually um, money saving? So there is a lot of thoughts which is beyond the scope of my lecture here, but this is a nice recent article that you might want to read if you are planning to build such system. Finally, I highly encourage everyone doing this or starting to do this to collect data in a standardized way. So research in this field has to have some primary outcome Mainly, we have to look at the incidence of chronic post-surgical pain at 3 months when we are establishing and evaluating transitional pain service. We have to look at the incidence of post-surgical opioid use at 3 months. Then secondary outcome, things like length of stay, emergency room visits, it's a big one. Readmission for uncontrolled pain is another big one, and some, of course, functional outcomes. Thank you for watching.